So welcome back, everybody. Just to introduce myself, my name is Sandra Arevalo. I'm the Director of Community and Patient Education at Montefiore Nyack Hospital. And today we're going to be talking about coronary artery disease. I have a spectacular guest today who is going to be our expert is Dr. Mark Greenberg. Dr. Mark Greenberg is the Director of Cardiology Services at Montefiore Westchester Hudson Valley Division. He's the Associate Chief of Cardiology Division of Montefiore Einstein Center for Heart and Vascular Care, Professor of Cardiology and Radiology at the Albert Einstein School of Medicine. And as if that's not enough, he's also currently the Director of Cardiac Cath Lab at St. Luke's Cornwall Hospital, former Director of Cardiac Catheterization Lab at Montefiore Moses Division, White Plains Hospital, and Chief of Interventional Cardiology for Montefiore Medical Center. I think he's a busy guy, and we're very lucky to have him with us today, spending some time answering our questions. So just a reminder that this is supposed to be a dialogue. So please take advantage of the chat box and the Q&A boxes. Write all your questions that you want to ask the doctor. I'll be happy to read the questions to him. And without further ado, I just want to introduce Dr. Greenberg. And Dr. Greenberg, do you want to start by telling us something about yourself? How did you become a doctor? Something about yourself.
Well, thank you. The one thing I would add is that hopefully in a couple of weeks, the Cath Lab here at Nyack Hospital will be open, and I'll be the director of the Cath Lab here in Nyack to get it going. It's very exciting. The beautiful lab, beautiful facility, great people. So I'm very, very enthused. Yeah, it's an interesting question. I didn't really think about being a doctor when I was young. It was a while ago, and it was a social thing. It sort of was, I always grew up thinking it was beyond my grasp. But then when I got to college, I realized it was within my grasp, and I sort of evolved into it. But it's been a fun road, yeah.
Well, from not even thinking about medical school to going all the way to cardiologist, something changed there. What was that?
Well, those that you could evolve. Actually, believe it or not, my original interest was in psychiatry, and then it was in obstetrics, and then back to psychiatry, and when I came to Montefiore for my training, I sort of fell in love with cardiology. You have to train in medicine first, and I just fell in love with cardiology. It's a very a lot of science, a lot of physical diagnosis. It's just something that I grew to love, and so I continued. Yeah, but it's a very, very interesting field. I still love it.
Well, thanks for sharing with us. Now, you just mentioned the Cath Lab. Probably a lot of us aren't familiar with that. Like, what is that, and how does that relate to coronary artery disease or just heart disease?
So, in general, we divide, tests into what we call invasive or non-invasive. Non-invasive tests are things like an echocardiogram. It's an ultrasound of the heart. You can do, sometimes with a CT scan, you can take pictures of blood vessels. Same way as you can take pictures of the blood vessels in the brain and the head and everything out in the belly. There's nuclear medicine stress tests. Those are all non-invasive. Catheterization laboratories for new procedures, both diagnostic and increasingly over many years now, do things that are therapeutic. So, dwelling down on the coronary arteries, is which most people are most affected by. In the cardiac catheterization lab, we actually take pictures of the individual blood vessels. We snake a small tube called a catheter through one of the blood vessels, and it goes to the heart. And when we position it at the main artery of the heart, we inject X-ray dye and we take pictures and identify if there's any blockages. So it's an invasive test. It's safe, but it's an invasive test. So you know, we use all these tests together, you know, to decide what's best for the patients.
Mm-hmm. Okay, thank you for sharing. And now let's get into business. What is CAD, or coronary artery disease?
Well, you know, atherosclerosis is a disease of aging of the blood vessels. You know, some people are higher risk, some people are not at high risk, but you know, to some extent, it's going to happen to, you know, a lot of people. And it's where the inner part of the blood vessel gets thickened, and if it gets thickened enough, can actually obstruct the blood flow to the heart. Or you know, the same thing can happen in the brain. It could happen in the legs. It's usually a systemic problem. It can happen in any organ, but when it happens in the heart, it can affect the heart. It can affect, if you don't have enough blood flow to the heart, it may limit your ability to exercise, and its most serious manifestation is when the blood vessel closes completely and suddenly can cause a heart attack. So it's something that we try to prevent, and if we can't prevent it, it's something we try to treat.
Mm-hmm. So who is at higher risk for CAD?
Well, you know, we call these risk factors. You're right. We call these risk factors. You know, patients will often ask me, you know, what causes this? We can't say that this causes that. So these are risk factors. You know, so if somebody has high cholesterol, if someone smokes, people with diabetes, I think I mentioned family history. You know, those things are risk factors. You know, for coronary disease. Obesity to some extent. But sometimes when I'm talking to patients, it makes it sound like I'm coming over judgmentally, you know, that you know, it's your fault that, you know, that you have this illness, you know, sort of like a blame game. And it's not fair, and I don't like to do that. So I have a little thing that I tell patients that it's like my father always taught me, if you don't smoke or drink or chase women, you don't live any longer. It just feels like it. So, you know, it affects some people, it doesn't affect others. So all we can do is try to control the risk factors that we can control. And there are people who have none of these risk factors and still come in. I had a patient at White Plains, I think now it's 2 weeks ago, 33 years old, came in with a heart attack. Without any of these problems. So it you know, or at least, you know, we have to do more testing and maybe things we haven't realized, but none of the common risk factors. So it can occur in anybody, but those are the things. And if one can control the diabetes and blood pressure and cholesterol, you know, one can really greatly reduce the risk of this kind of thing progressing.
Does that something have to do with family history? Like if somebody gets CAD younger?
Yeah, yes, absolutely. Family history. You know, again, a lot of times there's these risk factors in the family, but family history in and of itself is a risk factor. But, you know, it's something you can't change. You can't change your family history. You know,
Yeah, you can change your genes. Not yet.
If you're at risk, then you may be more cautious and more interested in being screened for the other risk factors to try to prevent, you know, the illness.
Yes. So does CAD usually affect younger people or the older people? Is there like an age cut for the disease?
I mean, it can affect, I mean, usually it's unusual for it to affect, you know, very young people. Like I said, this man was in his 30s with a heart attack, but, you know, we've had patients in their 30s and 40s, but, you know, the risk, you know, as you get older, the risk, you know, gets greater just because and to some extent it is, you know, part of aging, but it can affect anybody, you know, there's a difference in how it presents between men and women also. Women, it tends to present later in life than men.
Okay. Are there some symptoms that we should be looking for?
Right. Right. I mean, in terms of, blocked blood vessels, the most common is what we call angina.
Okay.
When the heart doesn't get enough blood, it aches. And what I make an analogy, so that when somebody's young and they're running very fast, they start getting cramps in the calves of their leg. The calves, they get these muscle cramps because they're running. So why do they get those cramps? They're running is because they're making the muscles in their leg work so hard that there's not enough blood going down there. So these muscles develop lactic acid, and that causes aching in the muscles because there's just not enough blood going on, not enough oxygen going to those muscles. So the same thing is that if we exercise beyond the limit of the blood supply to the heart, you can get the same kind of aching, in the heart, the same as you get if you have a cramp in your leg. And so people a lot of times will think that, chest pain is like pain, like they're getting stuck with a knife or something like that. It's really not a painful thing. It's when somebody gets it, it's more like an ache. And people have a hard time describing it. It's a sense of, pressure, aching, but it's not like, a pinpoint pain. What I tell people is if you could point with one finger to where your pain is, it's not your heart.
And usually, I've heard people who confuse like a stomach ache or like gastric reflux with angina. Is that common, or is that even related?
It's not uncommon. I'm sorry, it's not uncommon because it can affect in different ways. I mean, classically, it's in the chest. Sometimes people feel it down in the pit of their stomach. The most common thing that we look for as cardiologists is the relationship with exercise, because these things usually come on when you're exercising. It doesn't mean you have to be running, but when you exercise, you're walking up hills, you're walking up stairs, you're going for a brisk walk, your heart rate goes up, your blood pressure goes up, the heart needs more blood, and the heart's not getting it, and so it starts to ache. So the relation, people have symptoms related to exercise, it sort of puts a light bulb up in the cardiologist's head there, like the cartoon, to make us suspicious that if it's exercise related. You can be at rest, but if that's less common. If you're having the symptoms at rest, it means there's something very serious, because that means that there's very low blood supply getting to the heart. But these other symptoms, if they're, we try to parse it out, and see, well, is this related to exercise? Is this related to eating and things like that? But symptoms related to exercise are important. I once wrote a paper. I saw this patient as like the third or fourth doctor he saw, and he had headaches. He had these headaches. He described them as headaches. And he went to various people, they did other things. And so he went to the headache clinic at Montefiore. At the headache clinic at Montefiore, they said, okay, here's a diary. You write down every time you have a headache. So he has a headache when he was running for the bus, he had a headache when he was swimming. Everything was related to activities. So they said, that's interesting. So they sent him for a stress test, and the stress test was markedly abnormal. So a number of years ago, he had his bypass surgery, and his headaches went away. So it's an unusual manifestation of angina. Headaches unusual, but as I wrote in my paper, it's not unknown. And you're right. And so separating, a lot of times the symptoms could be in the jaw. Again, but it's related to exercise. So I've had patients who've had a lot of dental work done because their symptoms were related to the jaw, and then they came and we fixed the heart, and the jaw pain went away. But it's that relationship to the activity of walking the stairs, the hills, bicycling, something. And so if the jaw pain comes when you exercise and goes away when you rest, it's much more likely that that's a manifestation of the heart, and that the dentist, although it may be a very nice guy, is probably not going to be able to help you that much.
Now, I know that a sedentary lifestyle is not a good lifestyle, but just listening to you, I feel like maybe we shouldn't exercise not to feel the pain.
No. I mean, no, you shouldn't. No, you should. Exercise is good. Like I said, it keeps your weight down. In and of itself, it's probably good for the heart. Um, you know, and in fact, people who are fit, even people who have heart disease, if they're physically fit, they're going to have less symptoms. Because if one is in good shape and physically fit, when they exercise, their muscles and their legs and arms and everything are better trained. So if you're physically fit and you exercise, those muscles don't need as much blood.
Okay.
You know, that you can get by with less blood. That's the idea of being trained. You know, the training is in your legs and your whatever your muscles you're training, your legs, your arms, or whatever. So if you exercise and you can do the exercise, you don't need as much blood, and you're not going to have as much angina. That's why cardiac rehab is so important, and it's for people who undergo these angioplasty stents putting in, people who've had heart attacks. It's actually quote unquote required that people go to cardiac rehab. And the hospitals are judged by what percentage of patients they're able to get into cardiac rehab, because the cardiac rehab actually has been shown to save lives. So sedentary doesn't help.
So how much exercise and what type of exercise is recommended to prevent CAD?
Well, I mean, it's hard to say. It's basically what people can do. Usually average around 20 minutes a day of brisk exercise, most commonly walking. One doesn't have to lift weights, this and that. And certainly walking, because those leg muscles are the biggest muscles in your body. So if you train those, you're going to be in very good shape. So, brisk walking, for 20 minutes is going to really help.
Okay, let's talk about weight a little bit. We know that weight is also a risk factor for heart disease. So when does weight become a risk factor? How much weight do we need to lose? Any pointers on how to keep a healthy weight for a healthy heart?
It's an epidemic. All you have to do is turn on your TV, and the commercials, the guy will tell you what you do to lose weight, right? Every TV show during the commercial, they have ideas on how to lose weight. And, it has to be a combination of exercise and diet. And, obviously some foods have more calories and more fat than others. So people usually know how to lose weight, they just don't want to do it.
But it's hard. It's hard. A lot of people want to do it, but it's so hard to get to.
Yeah, whatever. But they want to do it, but they just don't. Smaller portions, healthier foods, more salad, more roughage, things like that. To make you feel less hungry. High carbohydrate type of medication or food rather. It tastes good, but it goes right through you, and 5 minutes later you're hungry again. And there's all kinds of extremes. We have one doctor at Montefiore who's a big advocate, and it's very, and it's a very healthy diet. He's plant-based diet. You've probably heard about plant-based diet. And people say that if you do a plant-based diet, then you're bulletproof. You're never going to get heart disease. But it's like almost impossible. I mean, you certainly can never go to a restaurant. I mean, if you think about it, I mean, you can't do it. So there's all kinds of diets, but a reasonable diet, restricting your calories, having salads, with your food, to get roughage in there to, make you feel less hungry. Eating meat, but smaller portions of meat, and stay away from the candy.
Yeah. Now, talking about epidemics, diabetes is like another huge epidemic. So how does diabetes relate to coronary artery disease?
Well, it's a risk factor. It's a risk factor in and of itself, and in patients with diabetes, to some extent, behave differently in our you know, and the indications to do things are different for people with diabetes. So, you know, diabetes is a very complicated illness. There's basically, they go into two groups. You know, those that are older, we call adult onset diabetes, often able to be treated with oral medications are one group. Often they respond to diet. People who are younger and more often and require insulin is a little bit different. You know, the younger group, their body's just not making enough, it's not either not making any insulin or not making enough insulin. And that's something that's not within their control, and it's difficult. You know, the older populations, they're making insulin, but because of obesity and other issues, the insulin is just not being used effectively. And those patients can often, between combinations and weight loss, can, you know, dramatically, you know, affect their diabetes. But in this day and age, you know, we can measure, you know, the person's control. I'm sure people in the audience here have heard of this test called the hemoglobin A1C. And nowadays, you can get that test, and that tells you what your blood sugar has been over the last few months. You know, so if you test your blood sugar, you know what it is at that point in time. This gives you an idea of what your blood sugar has been doing over the last period of time. And depending on what your hemoglobin A1C is, it gives you an idea how far out of whack your blood sugar has been. So if you get 6, 7, 8, 9, you know, very high hemoglobin A1C, means you're not doing well. And doctors and diabetes specialists, that's what they use to get an idea of whether or not these people are controlling the diabetes. Unfortunately, you know, unlike other things, you know, diabetes, my wife is an endocrinologist and a diabetes specialist at Mount Sinai. And unfortunately, it's really a partnership between the doctor and the patient. It's not just to take these medications. People have to know, become sophisticated with their own diabetes, and work with the doctor. But it's a shared responsibility.
Okay. And so now what about high blood pressure? Because that's, I think, another risk factor in how does affect us or affect our heart.
I mean, high blood pressure is an issue in two things. It is, as you said, it's a risk factor, you know, for developing atherosclerosis. But in addition, you know, the heart is sort of is more complicated. People tend to concentrate on the blood vessels. But in the heart, you have the muscle that's contracting, you have the blood vessels that's giving the blood supply to that muscle, and then you have these valves that's making the blood move in the right direction, that it goes forward without problems. So high blood pressure can affect the muscle of the heart itself, you know, whether you have blocked blood vessels or not, and that effect on the heart can affect people's, you know, symptoms and shortness of breath and their longevity. So high blood pressure is, you know, is a double threat. One, that it raises the risk of developing blockages in the blood vessels that supply the heart. It can have a direct effect on the heart muscle. As I tell people, it's as if, you know, you see these Weight Watchers, weightlifters, and they're lifting weights. And you look at them, they look like Arnold Schwarzenegger, look a little funny, because they have these huge muscles from doing all this heavy lifting. Well, you know, it's not good when your heart's doing this heavy lifting all the time, because it has to pump against this high blood pressure. So the blood pressure also will become like that. And we don't use that term. It's a Mark Greenberg term that I use, but it's like the heart can become muscle bound, because the heart has to work all the time against this high blood pressure. So what does it do? It gets thickened. In some regards, it gets stronger, but it gets stiffer. And people can, you know, a lot of people that we see now, the blood vessels are perfectly fine, but the heart's just not relaxing properly, because the heart, in my terms, not a medical term, in my terms, it's like muscle bound from having been subjected to high blood pressure for such a long period of time.
So controlling your blood pressure, I guess, is going to also help you control your heart
Right.
disease. Okay.
So
now let's.
sorry, fortunately now we have a whole array of medications, that are available, and a lot of them are very well tolerated. And then also, weight control and exercise also will affect blood pressure.
Mm-hmm. Now let's go back to the topic of diabetes, because we got a question from Patrick Dupee. For an active adult, what is the desired range for hemoglobin A1C?
You got me. I don't want to say I'm going to give you the wrong answer.
Well, I can answer that if you allow me.
Go ahead.
So it's a 7. So A1C should be, if you have diabetes, it should be less than 7. If you don't have diabetes, then 6 or lower will be what you want it to be.
It should definitely be less than 7.
Yeah, definitely less than 7. So I hope that helps. Okay, now let's talk about like diagnostics. How do you diagnose CAD? What lab tests need to be done, or diagnostic tests?
Well, it's a complicated field. The most important thing is the doctor to talk to the patient and try to parse out whether or not they have symptoms of from the heart. As I said before, we separate these tests into non-invasive and invasive tests. Usually we reserve the invasive test, the heart catheterization test, for those people who we think have the more severe disease, or in which the other tests just don't answer the question. They're too ambiguous. One thing that's very hard to get patients and sometimes even doctors to understand is that when people have these blockages, you can treat them medically. It's not like we're on a crusade that every time we see a blockage that we have to put a stent and open up the blood vessel. That's not been shown that it's important. What I tell people is that there's 2 reasons to muck with the heart. One is to make them feel better, and one's to make them live longer. So if somebody is having symptoms that sound like it's interfering with their lifestyle, they're having trouble running to the bus, they go into the city and they can't walk up the stairs to the train, or up and down the stairs to the train, and their symptoms, that's one level. People who don't have symptoms, it's something else, because if somebody's not having symptoms, then for me to do a procedure, I have to look at the person with a straight face and say, if I do this procedure, I'm going to make you live longer. That's a more complicated thing to promise. You can make them feel better by getting more blood to the heart, but are you going to make them live longer? And we've had lots, cardiology is a very, very well studied field in medicine. And we have criteria that statistically certain procedures, certain types of blockages, when they're fixed, that the people will live longer. But people think that when they come in that everything has to be, they want to be made 20 years old again. They want to get rid of every blockage in the heart, and that not necessarily something that helps people, and in some situations, could hurt the person.
Yeah, I feel like most people, and this is how I always tell people, is like, if you cut a finger, you got to put a bandage first. Maybe if it gets infected, get some antibiotics, and, ultimately, like, cut your finger off. But, most people are just looking straight into surgery and things like that. So
yeah, it's like anything else, back surgery and everything else. You're absolutely right. So I've never been a fan of these executive physicals where, where they're screening people without symptoms. It's a complicated thing, but that, the accuracy, if you use that term, of these tests depend on who you're testing. It's a complicated formula. So, I told the story. So I have, my daughter, she's in her 30s, and then she runs marathons. So if she went for this test for no reason whatsoever and it came back abnormal, the chances that she had any problem with her heart is almost 0. She's young, she has no risk factors, she has nothing. the saying, you know, of a person, some 60-year-old person with active angina, it goes through the test and that becomes abnormal, then the chance that that test really shows that there's a serious blockage starts getting to 70, 80%. So you have to, even when you go for the test, you have to interpret it in terms of what's going on with that person. It's, you know, people say, you know, and when we get these results back, we don't say it's positive or negative. I mean, that's what the patients want to hear. But when we say, what's the predictive value? What's the chances that that person has heart disease? So a lot of times I'll make an analogy to a woman going for a mammogram. And the mammogram shows something suspicious, but the biopsy's okay. So that's a screening test. And you don't want to miss anything, but you don't want it to, you know, be too silly. So it's, you know, the testing, you know, is best done together with your doctor and starting off knowing where you are, whether or not you're having symptoms, whether or not you have risk factors, and what's the question that you want to ask and answered.
Mm-hmm. So, Dr. Greenberg, once you're diagnosed, so let's move past the diagnosis. Once you're diagnosed and God forbid you had like a heart attack, is there a higher chance to then have recurrent heart attacks? Or, you know, you just have one and if you survive, you shouldn't worry about it. You know, once I had a patient that he had like 7 heart attacks and he was like, you know, heart disease is not gonna kill me because it hasn't killed me yet, but I was always nervous for that patient. So how does that work?
First of all, you know, heart attacks come in 2 flavors now. There's heart attacks, which, you know, the big heart attack, we call them ST elevation, where the blood vessel actually closes completely. And those are the kind of things where I get woken up at 1, 2 o'clock in the morning. And from the time that patient shows up in the emergency room, you know, I have a timer. And I usually can do it within 45 minutes or an hour. But if it gets, you know, including running to the hospital, if it's over 90 minutes, the hospital gets dinged that they didn't provide adequate care, if there's no other reason. So, you know, that's an emergency. The vessel's closed completely and you have to open it up. And that's the kind of things, that's why they're opening Cath Labs at Nyack and other hospitals to make the, you know, the treatment center closest to the patient so they don't have to spend so much time traveling. The other heart attacks are the smaller heart attacks where the blood vessel's still open and there's blood going through, but either the blockage got a little bit worse, the person exercised a little bit more. The basic answer to your question to preventing it is risk factor modification, but the most important is controlling the cholesterol. And nowadays we have medications that we can meet a new goal, which is the bad cholesterol, what we call the LDL, you know, the bad cholesterol, to get that below 70. The old target was 100. Now we know that if you get it below 70, people do even better. Nothing's 100%, but we have, you know, the medication now that we can get it below 70, and obviously the medication plus, you know, diet and everything else. So generally what we push in patients who have had a heart attack, get that low density lipoprotein, that LDL below 70, cardiac rehab, and then you know, weight reduction, which is somehow difficult, you know, for a lot of people, and to get that, you know, hemoglobin A1C and the diabetes under control, and certainly please stop smoking.
Mm-hmm. Now you're talking about LDL. I know there is also HDL, high density lipoprotein, that is supposed to be like a good fat, right? It has a protective factor. So if your HDL is high, will that help you subsidize the fact that your LDL might be high as well? You know, like some people have high LDL, but they also have high HDL. Some people don't even have both. Like, but is that good, or is that still a fact?
It goes in the equation. So the LDL, when the doctor says you have such and such LDL, the HDL has already been subtracted from the total cholesterol.
Wow.
So you
Oh,
start with the
really?
total cholesterol. You subtract
Okay.
off, you subtract off the HDL, and then the triglycerides, which is a less common risk factor. You divide that by 5 and subtract that, and what you got left is what we call the calculated LDL. So,
Yes.
when they say the LDL is such and such, it's already factored in the HDL. And also, not all
Okay.
and also we know most of the time HDL is the good cholesterol, but not always. There are some people where it's not, but in general, you're right, it is. But
Mm-hmm.
but not the entire population of planet Earth, but those people who have had heart attacks, heart disease, procedures done, getting that LDL below 70 is the new target. And yes, it's medication, but it's an easier target to achieve than even controlling blood pressure or losing weight or things like that.
Mm-hmm. Dr. Greenberg, can we talk numbers a little bit? Because now, obviously this conversation is sparking people to ask, and what are the right ranges? So we're saying LDL should be less than 70. Do you know what the HDL should be?
Well, I mean, you can't do much to control it, so we don't concentrate. I mean, over 50 is good. In general, it's
Okay.
good. But it's something that we don't really have a medicine that will increase the HDL. So it's like your family history. I mean, we try to concentrate on those things that we can do something about. So
well, they say fish oils.
Your HDL is not that high. Sorry. Talk to the guy upstairs. Talk to your parents. I can't do anything about it. It's over. But the LDL is something that you can control.
Okay, so LDL you can control. What about fish oils? I've heard, if you take omega-3, omega-6, and all of that,
it's pretty
that can
controversial.
help.
I just did an hour-and-a-half course on this. In randomized studies, it's not been shown to be that effective. There's one product that's a prescription product, and it's a little bit expensive, and it's not used that much. The fish oils are best for the triglycerides. It's the other part of the fats in the blood that we talk about, but not that much. But they've not actually had good studies, research studies, but the fish oils over the counter have actually reduced it, and especially since they look at high risk patients, and if you look at the whole population, you're never going to show it's an effect. So you have to do it people who are at high risk, who have high triglycerides, where fish oil has been the most effective. And even in those studies, they've not, except for this one prescription product that requires a doctor's prescription, that it's not really been proven. A lot of the over-the-counter, things have not really been, when subjected to rigorous testing, haven't been effective. And the fish oil thing is, there's been a lot of research on the fish oil.
Okay, so we don't need to bother with that, apparently.
Doesn't hurt. There's no evidence that you take the fish oil, it hurts. It just may hurt your pocketbook.
Yeah, exactly. That's hurting enough. So what about treatments? Let's say after you have your first heart attack, also, what's the prognosis? Are we supposed to start thinking this is the end of our lives? Or, is there a good prognosis to all of these?
So there's a good prognosis. I mean, what we can do now compared to the old days, when I was a child, the President of the United States was Eisenhower, and he had lots of heart attacks, whatever. But now there are things that we can do. We have a lot of medicines to prevent it, and I take care of a lot of people who had heart attacks for a long time ago. My own rabbi had. Let me just turn that off here. My own rabbi had a heart attack, 34 years ago.
Oh, wow.
And he had a stress test, I think a week ago, maybe 2 weeks ago, something like that, week, 10 days ago. He did a lot of exercise. He did a lot of exercise. He got his heart rate up. You know, he's obviously older now than he was 34 years ago. But he's going strong. I won't mention him by name, but he does a lot of traveling. He's a very well-known person, and you know, does a lot of writing and stuff. So, you know, and obviously he had his illness presented at a relatively young age. So people can live very active lives.
Mm-hmm.
So again, you know, having a heart attack doesn't mean, you know, the family should get you a wheelchair for Christmas type of thing. You know, you know, between rehab, controlling the LDL, and to some extent, you know, procedures. You know, if you know, there's certain procedures that either we open up with a stent in the Cath Lab, dilate the blood vessel, open up the blood vessel. Certain situations that have been shown to allow people to live longer. Statistically allows people to live longer.
Mm-hmm. And what follow-up is necessary after you have a heart attack? How often do you need to be seeing the doctor? What tests you need to start?
Yeah, I mean, people, you know, should follow through with their, you know, their cardiologists, and you know, different cardiologists have different, you know, different attitudes towards this. Generally, again, you know, the risk factor modification, you know, controlling, you know, the cholesterol, controlling the blood pressure, controlling the diabetes. When we put stents in, you know, we use certain medications, aspirin and/or other medicines like, you know, Plavix or Ticlet or something like that, that patients have to make sure that they use. You know, some doctors will do routine stress tests in people who, you know, who have already identified heart disease. But, you know, I think an active lifestyle, controlling the cholesterol and controlling other risk factors, I think is important. Mm-hmm. And that's it. And people, like I say, people can live very, very, very long period of time, you know, without, and most people die from something else, basically. They don't usually, people with heart attacks usually die from things other than heart disease, I mean, because they're living much longer.
Yeah.
People, it's amazing, even I still consider myself relatively young, the advances that have taken place, even within my time in medicine. Don't get depressed, be happy, exercise, go to the doctor, control your cholesterol. And for some people, it's an awakening. People have, and they lose all this weight, they become different people, they start exercising.
Yeah. I've had patients like that as well.
Yeah.
Like, you know, they
were
obese to start with, and then after that, you know, after a heart attack, they get to be the healthiest people. Yeah.
Some hospitals have actually, you know, formal American Diabetes Association license, you know, approved, you know, diabetes education programs, you know, where people can go.
Weight loss programs.
Yeah, you know, people can go and they get a very intensive experience in terms of controlling their diabetes. And that's often sometimes like an awakening where they can learn about their diabetes and what makes their blood sugars go up, and what do you do, you know, if you want to eat cake, how do you do it, and things like that.
Yeah, as a matter of fact, I don't know if you know this, but we do have a certified American Diabetes Association self-management program here at Montefiore Nyack, and also a weight reduction program. It's the diabetes prevention program. That is a weight reduction program, actually.
It's extraordinarily helpful. I mean, I can tell you, like I said, like, my wife was a diabetes expert, you know, and very, very prominent in the field. And I can tell you that those things are extremely, extremely effective. I mean, and they could be a real game changer for people.
Yes. Yes, absolutely. So for all of our attendees, if you are interested in learning more about the diabetes self-management program or the weight loss program, you can go into Montefiore Nyack website and go into the community programs, and you're gonna find it there. It's easy to get enrolled and everything. It comes out of our department as well as community education.
I would strongly recommend it. You know, because as I said before, when we talk about diabetes, it's a shared thing. You know, you see your doctor every 2 or 3 months, you know, and it'd be, you know, how long is it going to be? 10 minutes, 50 minutes, 20 minutes, 30 minutes. And then you're on your own, you know, whatever, you know, and so you have to learn how to do this. It's a lifestyle thing. And I think it's, you know, they didn't always have these things, but now I think they're extraordinarily helpful.
Yeah. You know, once I saw like a comic, I don't even remember what I saw these, but it said something like, you know, it's the doctor talking to the patient, and the doctor was asking the patient, do you prefer to exercise 20 minutes a day or be dead the rest of the time? You know, I thought it was funny. Like, of course, you know, like sometimes we need to think about it that way.
A lot of times you know, the patients may not be, you go to the doctor's office, they may not be the best role models either.
Yeah, no, I agree with you. Yes, absolutely.
The doctor, yeah. You know, you're talking about weight reduction, but doctor, cure yourself.
Yeah,
so
and doctors with hope and all of that. Yeah, absolutely. Yes. So, do you think people with heart disease need some type of support to coping with the disease? And if so, can you give us any pointers, you know, where they can go for support?
No,
and that's Sindhu in the back. We all see Sindhu. So she's the director of the Cath Lab, actually. Hi.
Yeah, I mean, I don't know, you know, again, I'm relatively new to Nyack, but, you know, Heart Club often is good. Sometimes people, you know, there's an extreme. You know, some people, you know, when they find heart disease, you know, they get actually depressed, and they need somebody to talk to and, you know, and support. You know, usually not medicine, but, you know, they need reassurance and things like that. So, you know, you know, and it goes in the extreme. Some people, you know, get very depressed, and some people go the other extreme and they deny. They're deniers. Mm-hmm. So you can't, you know, I don't need the medicine. I don't have to stay in bed. I'm going home now. Whatever. But you know, you need to know the road. But there are people. I don't know. Do we have a heart club here at Nyack? I don't know. I don't think so.
Not that I know of. Actually, I think we've been trying to start like a support group and an education program for people with heart disease and strokes. Like, you know, so.
What we're doing now may be more sophisticated. You know, the Heart Club may be something from, you know, before the turn of the century type of thing. You know, maybe these kind of Zoom things where people can do the same thing, you know, online.
Yeah.
You know, we can reach a larger number of people, record it, play it back. This may be, you know, reporting, giving people support. But sometimes just being in a room with other people, there's like a little socialization and things like that, that, you know, people feel they're together with a community that's been through the same thing.
And to hear stories, right? Like you just said, like your rabbi is being alive after a heart attack over 30 years. That gives you hope, actually. You want to be that person as well.
Not only, I mean, but I'm telling you, I mean, he probably did more exercise. I mean, maybe not, but he did a very good exercise. I mean, he got his, you know, we measure people, the exercise, how good it is by how high you get your heart rate. And he got to like 95% of, for his age, what was predicted. And he didn't have anything. I mean, it was a perfect stress test. So, you know, but he's obviously, you know, we've taken care of him for a long time, and, you know, he's had to have some procedure, he's had some medication, but, you know, 35 years later, he's a very active man, international travel and everything.
Wow, that is great to hear. So we only have 5 minutes left. So I'm encouraging all of our participants today, if you have any questions, please go ahead and write them in the chat box or the Q&A box, because we're about to be done today. Any other thoughts, Dr. Greenberg, that you would like to share with us today about CAD or the cardiac rehab program that we have here, or the Cath Lab that is opening on February 1st?
Yeah, I think, and the last time we talked about, I think having a catheterization laboratory, you know, in the community is helpful. This whole thing has sort of evolved over a number of years. So at one point, catheterization laboratories were limited to large university centers, and the whole thing has evolved over many years. So people who are there and whatever, just to assure them that having a catheterization laboratory and doing procedures like this in Nyack is safe, and we have to. In cardiology, we have to report our statistics. We're graded. We're measured. We're measured by the New York State Department of Health, and we're measured by national standards called NCDR. It's American College of Cardiology. Our outcomes, complications, all those things are looked at very seriously, and we're competing against large New York City hospitals in terms of outcomes. And in general, we do very well. I've been at, I'm still at Montefiore, but I've also been affiliated with White Plains for over 6 years now. And the safety and efficacy and what can be offered in a hospital like this is comparable to what we can do in city hospitals. There obviously are going to be some procedures that are so complex that you can only do it at a place where there's on-site surgery. But those are very specific and very detailed things. So I think that people like it better. They don't want to go into the city, they don't want to cross the bridge, and they want to be treated where they feel comfortable. So I just reassure people that's it. And for the heart attacks, the real heart attacks when they come in, having a cath lab right here, where they can come in and have this clogged blood vessel open within essentially an hour, is a major thing for this community.
Mm-hmm. Yes. Well, thank you so much for sharing all this knowledge. It's really great. And I'm getting a comment here. It says, hi, Dr. Greenberg, cardiac rehab team here. Great discussion. We're looking forward to working with you and your team to help patients with CAD improve their health outcomes. There you go.
It's interesting.
Thank you, James.
It's interesting that people poo-poo cardiac rehab, because, cardiac rehab, what about just give me a pill? Just give me a pill.
Yeah.
And I'm telling you, in this day and age, the insurance companies and the government of the United States would not be paying for cardiac rehab unless it had been shown to make people live longer. It just wouldn't happen. The insurance companies aren't paying for people to go to cardiac rehab after an angioplasty or after surgery, just because they're a bunch of nice guys. They're paying for it for a reason, because it's been proven. And it's an outcome measure that has been proven, in studies. So it's a scientific thing. It's not just a feel-good thing. It's a scientific thing that's very helpful. So kudos, to your cardiac rehab team here at Nyack.
And not for nothing, part of the cardiac rehab here is beautiful. It's it's like a state-of-the-art gym here. It's so clean. It's beautiful. Its own entrance. So if you haven't stopped by the cardiac rehab, please do. It's gorgeous.
And also, so, they call it getting back on the horse. Sometimes people are intimidated. They're afraid to do things. So, they're in the hospital. I shouldn't be doing this. So you're in a rehab situation where you see how much you could do. It makes you feel more comfortable to do things when you're out, when you're done, when you're out, when you're outside. Say, boy, I did a lot more than this when I was in cardiac rehab, 2 days ago. So it's a marvelous thing. It's a marvelous thing. Yeah. And I guarantee you, all these people would not be paying the bill if it didn't help. I'm telling you, that's what never happened.
Yeah. No, and you're being supervised. You have the support. You know what you're doing and all of that. It's really great.
These people are wonderful. They know their stuff. I mean, these rehab people are very, very good.
Mm-hmm. So they're also asking if we can do a similar seminar in Spanish for our Spanish community. So maybe you can get me in touch with Dr. Mario, I forget his last name, and maybe we can start planning a Spanish.
I mean, Dr. Ture is actually going to be one of the Montefiore cardiologists that's going to be here at Nyack.
And he speaks Spanish?
He's a full-time, he works for Montefiore, he has an office, I work with him, we have an office in Terrytown, but I think he's also Argentinian. But anyhow, so he's gonna be here, I think on Wednesdays here at Nyack. He does the cardiac catheterization procedures, he does office work, but he's a very good speaker, and I guarantee you his Spanish is much better than mine.
Okay, so I'll connect with him, and I promise in the near future we're going to have another one in Spanish.
He's a very nice guy. Yeah.
That's great. Now, just to get you updated, we have obviously more seminars in the coming weeks. Next week is going to be on cancer support, so all the support that we can offer to patients. And then January 28th is going to be diabetes support for women. So we're going to be talking about the National Diabetes Sisters Program, which is amazing. You don't want to lose that. And if you want to continue talking about heart and heart health, February is Heart Month, and in honor of Heart Month, on February 18, we're going to be talking about nutrition, exercise, and all of the things that you need to do to lower the LDL and increase your HDL and do your exercise and prevent heart disease. So you are all invited and welcome. Of course, I'm gonna be sending invites and Zoom links so that you can register. Thank you so much for your time, Dr. Greenberg. It's been such a pleasure having you today.
Very good. Thank you very much.
And I'm sure that we're gonna keep seeing each other going forward, so thank you. And thank you to all of our attendees for spending an hour of your time on this Thursday with us, and we'll see you next week. Thank you all.
Thank you. Thank you, everybody, for joining in.
Bye.